Hello, everyone. My name is Dennis Yang. I'm the director of Third Space Endoscopy at the Center for Interventional Endoscopy here at Advent Health Orlando and professor of medicine at Loma Linda University Health. On behalf of me and my co-authors, I want to thank the editors of gastrointestinal endoscopy and the viewers for the opportunity to discuss our multi-center study evaluating the effect of endoscopic submucosal dissection, or ESD, on the histological diagnosis of patients with Barrett's esophagus visible neoplasia. Accurate histological staging of resected Barrett's visible neoplasia is crucial to establish the risk of progression and to help guide the most appropriate treatment strategy. ESD facilitates the en bloc resection of any visible lesion, irrespective of size, thereby procuring an ideal specimen for histopathological assessment of resection margins, and most notably, the depth of neoplastic invasion. There have been several studies over recent years showing favorable outcomes of ESD for Barrett's neoplasia, but there is limited data on its potential value as a diagnostic and staging tool. Hence, the purpose of our study was to evaluate the overall change of histopathological diagnosis with ESD compared with pre-ESD histopathology for visible abnormalities in Barrett's neoplasia. This study was a secondary ad hoc analysis of a large prospective cohort study of consecutive patients undergoing ESD at 11 centers in the United States and Canada over the past 5 years. For this study, a change of histological diagnosis was defined as either upstage or downstage if the ESD specimen had either a higher or lower degree of neoplasia when compared to the baseline histopathology. In all, a total of 223 patients were included in this study. Median age was 69 years of age, and as expected, the majority of these were men. Approximately 70% of the lesions were located at gastroesophageal junction as opposed to the body of the esophagus. Approximately 1 out of 5 patients had undergone RFA treatment for Barrett's esophagus prior to ESD. The median lesion size was 35 millimeters, and the median ESD resection size was 45 millimeters. Median procedural time was 75 minutes. En bloc complete R0 resection with negative margins were achieved in 100% and 87% of the cases, respectively. Curative resection was attained in 71%. From a histological standpoint, baseline histopathology was non-dysplastic Barrett's in 7% of the patients, low-grade dysplasia in 5%, high-grade dysplasia in 31%, intramucosal cancer in 37%, and invasive cancer in 20% of the patients. Overall, ESD resulted in a change of histological diagnosis in 55% of the cases. Notably, the frequency and the change of diagnosis was similar between lesions in which the baseline histopathology was obtained by either cold biopsy forceps when compared to endoscopic mucosal resection, or EMR. Out of the 113 patients that had a change of diagnosis, ESD resulted in upstaging in 68% and a downstage in 32%. Importantly, in aggregate, approximately a quarter of cases in which there was a change of histological diagnosis were upstaged to invasive cancer after ESD. Conversely, 13 patients, or 6%, with a prior diagnosis of invasive cancer were downstage following ESD. A multivariate analysis, location at the gastroesophageal junction, and prior radiofrequency ablation were the only factors associated with a higher than twofold chance of a change in histological diagnosis following ESD. Our study demonstrates that ESD resulted in a change in histopathological diagnosis in more than half of the patients in our cohort, with nearly 1 out of 5 of these being upstaged to invasive cancer. Our findings further demonstrate that the risk of both under and overstaging based on biopsy diagnosis alone and its potential serious consequences on patient care. Importantly, there was a similar rate of change in histopathological diagnosis in patients who underwent EMR prior to ESD. While interpretation of this data should be exerted with caution given the small cohort and the potential for selection bias, we believe that this is a point that should deserve further attention in the future, as other previous studies have also alluded to some of the limitations of EMR as a diagnostic tool in this setting, particularly with larger visible lesions. So in summary, our multi-center study demonstrates that ESD led to a change in diagnosis in more than half of the patients with Barrett's esophagus visible neoplasia, highlighting the potential role of ESD as a diagnostic and staging tool. Hence, we believe that selective ESD should be considered, particularly in those cases where there's a high index of suspicion for invasive disease. Once again, I want to thank the editors of Gastrointestinal Endoscopy and all the viewers who tuned in to this author interview. I certainly welcome everybody to access our full study in gastrointestinal endoscopy. Thank you.